quality. Can you explain how to improve the quality category, Dr. Mingle?
Thanks, Kyle. John's intent with this question was to dig into his approach to quality, and there are a number of tools you can use to go after this. Let's first talk about submission mechanism. John's been using ECQMs. Now, if they're working well for you, it's a solid technique. It can be easy. It can be effortless. You push a button at the end of the year and you get your measures out, and if you can get to the Medicare, you're done. But there are a number of limitations. Pricing for that ECQM engine is a strategic decision of your EHR vendor that can make it either easy or hard. Some EHR vendors charge aggressively for ECQM delivery. Others include it in the core license. An EHR typically has to focus on a one-size-fits-all strategy. They either can't customize per client, or it can be overly difficult to maintain if they have. Now, there are third-party vendors doing ECQM work that's applicable to multiple EHR platforms. We're bringing our own processes live this year. Those independent third parties can be more customizable, but there's still limitations in the rules around ECQM production that don't limit MIPS CQM production, and those can be important differences. If you aren't getting the quality scores you want with ECQMs, consider MIPS CQMs. Now, ECQM failure points include first, configuration and implementation issues. This is about setting up the system to accept documentation of your clinical work. Sometimes choices that make sense to the users and to your local EHR support team can exclude data from the ECQM engine. I've seen templates for documentation that don't save the data where the ECQM engine can see it or access it. Other templates malfunction by overwriting old data with new, rendering historic analyses, which you often need for your quality assessment, making those analyses unreliable. MIPS CQMs can give you the flexibility to get the data where it actually lives. It can also give you enough core granular data, that is to be able to drill down to the performance of particular providers, drill down to the existence of particular patients in the data set and how and why they were judged to be performance met or performance not met. They can give you the data to identify and correct configuration anomalies. MIPS CQM is a great tool with enough data availability to prepare your practice for effective ECQM use sometime in the future, which is certainly a goal, maybe achievable, maybe not. Training and compliance can be an issue. If you set things up appropriately to feed the needed data to your measurement engine, it still depends on your users to follow the recommended documentation workflows. If they don't, you may not be able to find the data. I found clinicians can find a lot of clever, different ways to document that make more sense to them than what you intended with your quality measurement system. Now, MIPS CQMs can give you the ability to cast a larger net when looking for data to pick up documentation that lives in more creative locations. Now, measure limitations can be a big issue. There are fewer measures available as ECQMs than as MIPS CQMs. The ECQM inventory for 2025 is 47. There are 169 MIPS CQMs to choose from. You only need 6 measures for traditional MIPS. Whether you draw from the ECQM inventory or the MIPS CQM inventory, there are more measures than you need on either side. Now, many of you know too well, despite all the measure choices, it may be difficult to find 6 that are simultaneously suitable for your specialty and the unique aspects of your practice, or for which you can effectively access the data required for the analysis. Many measures are simply not designed to accommodate structured data easily extracted from EHRs, and many medical record systems and documentation workflows are not adequately designed to collect data in structured format that is easy to extract. Now, if all else is working, the measure could be in topped-out status, which is end of life for a quality measure and is usually accompanied in the early stages by a 7-point cap on the available performance points. It's hard to score above 75 overall and to get into the positive MIPS adjustment range if we're using measures that are capped effectively at 70. Now, of the 47 eCQMs, 21 are not available as MIPS CQMs. 26 measures go both ways. Every measure has scoring benchmarks to place your score in a competitive array with those of other groups. It's not so important how you perform, but how you perform in comparison to your peers. Benchmarks are set separately by method. The same measure generating the same performance rate in each CQM and MIPS CQMs might very easily give you a better score in one system than the other. And to further explain topped out, this is where all practices get a near perfect score. Such measures don't really differentiate between practices. Medicare doesn't like them because everyone's getting a high score. Medicare has mapped out a process to gradually retire topped out measures from use. The first action is to cap the maximum available points at 7 out of 10 for those topped out measures. Now, that topped out measure status is specific to the submission mechanism. eCQMs and MIPS CQMs are considered separately. A measure that is topped out and capped at 7 points in one mechanism may not be topped out and capped in both. Now, with fewer measure choices in eCQMs, you may not be able to come up with 6 solid choices without choosing some that are topped out. Measures topped out at 7, that is 70% of a perfect score, detract from your goal of getting that total score above 75. That is the positive adjustment zone. Now, how about improving your score? No measurement system is perfect. It's easy to miss data that would improve your score. You can correct either a MIPS CQM submission or an eCQM submission. It's easier to correct the MIPS CQM submission. Correction typically involves a data validation process, or they can be linked together. So let me make a pitch for an annual data validation process. You can use that validation process both to improve your system, to ultimately improve your readiness for eCQMs, and you can use that validation process to improve your score. Medicare requires data validation every year from a random sample of our clients. You may have heard from us if you hit that random selection. You are already engaged in that by invitation. Now, Medicare's interest is seeing the proof that for the patients you call performance met, that you can prove that you have data that makes them so. For your own use, you're more interested in the status of performance not met. We typically can trust that if we find data, it is data, and that's what usually defines performance met. The lack of data usually corresponds with performance not met. Of course, we reverse that in inverse measures, but that's topic of another discussion. Take as an example influenza vaccine. Finding a record of administration means that performance is met. Lacking data may mean that performance is not met, but it might also mean that it was not recorded or is not recorded in the immunization table where I'm looking for it. Now, our process and dashboard gives you access to a list of all patients for all measures with their performance status, including what data went into the status. I suggest you choose between 10 and all of your performance not met instances and cross-check by manually abstracting their medical records. If you find data in the chart that your data extraction missed, you found gold, with which you can improve your scoring immediately and your processes in the long term. In the short run, you can correct your submission. If you're using MIPS CQMs, you can take that sheet that you use to do your data validation, and you could submit it to us as a performance spreadsheet. And we can go through that, see which patients were actually performance met that we considered not met, and switch their statuses because you found the data. If you're doing eCQMs, you can correct the chart through whatever formal record correction method you follow. It's typically an entry made into EHR with an explanation for why it was made, and they sign off by the responsible provider. It's more time consuming, there's more processes involved, but it works. It puts the right data where it's supposed to be, and when you re-pull and resubmit your data, we get the data in the right place and improve your performance marks. In the long run, it'll help you fix your future quality submissions in one of two or a combination of both methods. First, you can identify the providers who are not documenting in a place that you look to get data for analysis. You can provide remedial training. This is how I want you to record vital signs. This is where I want you to record immunizations. And you can improve that record keeping and then improve the performance of your uh, quality measurement in the future. Second, you can expand your extraction queries to include the additional locations you've identified as holding pertinent data. So you don't always have to change your providers. Typically, if your provider is recording textual data, you can't pull with a data extraction, you'll want to change your performance. If they're just putting it into a structured spot you weren't anticipating, you can expand that extraction query.